Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. We are thrilled to be joined by Bev Morris and Kim Morris from the Center for Orthopedic Reconstruction and Excellence. Kim currently serves as the Director of Materials Management and Bev serves as the Director of Surgical Services. Located in Jenks, Oklahoma, CORE is an affiliated campus of Bristow Medical Center. The Orthopedic Surgery Center includes 6 operating rooms, 4 procedure rooms, 25 inpatient beds, a physical therapy wing, and a 24-hour emergency room. The $45 million, 51,000 square foot facility features the largest operating rooms in the Tulsa area and employs the latest and most advanced medical technology. We are also excited to be joined by Deb Miller, Senior Consultant Clinical Operations for Cardinal Health. Deb has more than 35 years of clinical healthcare and supply chain experience, including over 10 years as a clinical consultant with Cardinal Health ASC clinical team. She has participated in numerous clinical and supply chain assessments, the development and review of custom procedure kit programs and product trials in a variety of provider settings. Deb has also assisted providers in developing and implementing best demonstrated practices for product standardization, preference card management, case pick, and process improvement. Deb, I'll now turn the floor over to you to begin today's webinar.
Thank you. Hello, everyone, and thanks for attending. After today's webinar, you'll be prepared to discuss how a clinical assessment can identify best demonstrated practices for navigating change, describe how your PAC program can drive product standardization and cost savings, reveal the importance of fostering clinical and operational alignment, and explain the power of data analytics to improve performance and optimize the patient experience. Let's get started. First, by telling you about Cardinal Health's experience supporting ambulatory surgery centers and surgical hospitals like CORE. With more than 40 years of experience, Cardinal Health is a recognized leader with a top ranking for transforming the healthcare supply chain to meet new challenges around costs, revenues, and outcomes. In particular, Cardinal Health is a leading medical surgical distributor for surgical hospitals and ambulatory surgery centers. Each of the perioperative nurses on our clinical team averages 20 years of OR and supply chain management experience. As clinicians ourselves, we've walked in your shoes and have seen the challenges you face every day. More importantly, we can be a fresh pair of eyes to help you meet those challenges. And that's what a clinical assessment is all about. A clinical assessment can help you identify best demonstrated practices based on your individual facility goals. We look at clinical practices as well as products. How do products flow in your facility's environment, from the loading dock to the end user, the doc? We've trained in both logistics as well as clinical practices. We walk your supply chain to spot opportunities to improve. We help you navigate change. Are there new procedures and/or new physicians or a brand new building? New facilities such as CORE, we came in and put our hard hats on to walk the new construction site and help these folks optimize space and workflow. Targeting new ways to support clinical, operational, and financial performance is what we do. Identify waste, annualize its cost, and convert it into real savings. Optimize the patient experience to help them feel secure about this facility, their staff, and the supplies that are being used. And evaluate clinical practices. Identify current PAC, draping, workflow practices, and compare those best practices from other facilities and professional organizations such as AORN or AAMI. As an example, let's take a closer look at how well your PAC program is aligned with your procedure mix. For example, are there low volume PACs that you should eliminate or consolidate? Do you need a new PAC altogether? To find out, we first request your current procedure volumes, and these can be on an annual basis or a monthly basis. We create what's called a PAC matrix, which is the screen you're looking at now. Then we create a report. So the current procedure volumes for this example total about 5,700, and we've broken that down into PACs and then a monthly volume. We look for gaps in the alignment between your procedures and PACs so we know where to focus first. So in the above slide, we looked at volumes, and for example, this facility did not have a cataract PAC, but they do almost 3,000 cases a year, a monthly volume of 243, and these folks thought that a PAC might be a welcome addition to their program.
So how does a clinical assessment work? There are three major parts: identify process improvements and safety standards, maximize efficiency of the case pick process, putting as many items as possible into each PAC, which saves staff from having to pull multiple single sterile items for each case. Evaluate safety standards compliance, making sure that we use the correct products for each procedure. Assessing gown protection levels. We don't want to overprotect, for example, using an AAMI level 4 gown when a level 3 gown will work just as well. And optimizing draping practices, making sure we choose the right drape for the right surgical site without having to cut a drape to make it fit. Evaluate efficiency of current procedure supply. Validate that we have the right PAC for each procedure and matching your PACs with your current OR schedule. Determine supply chain impact on practice, throughput, and cost. Do you have the right quantities of inventory for your caseload, or do you have a habit of overstocking? Third, reveal level of returns to the case pick area. Are you picking too much? Fourth, seek supply consolidation opportunities for high volume, supply intense procedures. Which is better, creating a custom PAC or an add-on PAC? We know that in many ASCs, they do knee arthroscopy cases, and they probably have a custom PAC for that. But if they also do ACL procedures, they may not have a custom PAC. And oftentimes, if they have enough volume, we suggest what we call an add-on PAC. So it's just those specific supplies for an ACL that we could consolidate so they wouldn't have to pull them all single sterile. And then when they do a knee arthroscopy with an ACL procedure, we can just pull the large knee arthroscopy PAC and then the add-on ACL PAC. And both of those might be the ticket to cost efficiencies, cost savings, and efficiencies. Number three, uncover new cost savings initiatives. And we do this by identifying waste in PAC components. Typically, OR staff are accustomed to following routines, so they may not even stop and think about what they're throwing away. And if they're routinely throwing away the same product, we can look at the cost of the waste and identify savings. One example is having extra towels in a PAC to drape the back table cover. Oftentimes, this is a sacred cow that a lot of OR staff typically do. They lay extra towels on the back table cover, which is not only costly, but it takes extra time to do that. So we often would suggest wrapping the PACs twice, which gives you the automatic second layer, and then it's a cost savings over having cloth in the PAC. Exploring product standardization. The first thing we look at, product variability versus consistency. Across the board, if we have a custom PAC program that we're reviewing and we look at all of the commodity items other than the drape, because the drape is what identifies the PAC, but having the same needle counter, having the same skin marker, or same gowns in every PAC will promote cost savings as well. And we can run a component standardization report to identify the areas where that's possible. Review adding single sterile items to PACs. Fewer items to open means more efficiency, not only for the staff, but the surgeons can work faster. The room turnover time is faster and much more efficient. Cost and labor of trash can be reduced by as much as 50%. And then lastly, evaluating clinical practices to increase efficiency and savings. Easy access to the supplies means more time for patient care as well. One way we increase efficiency and savings is by using what we call the baseline tool. It helps us create the most cost-effective product mix for each procedure pack. We look at the current practice cost versus the pack cost or the proposed practice cost. The example above is of a baseline tool that one of our reps utilized for a cystopack. On the left side of the example, you can see the current items, the single sterile items that staff pick for their procedure, and the total cost of all of those items. On the right are the cost savings achieved by switching to a consolidated cystopack. The per procedure savings is $1.79, but when you multiply that by 110 procedures a month, you save nearly $2,400 per year. And those savings can really add up once you start cutting waste and improving efficiency. Now that we've covered the basics, let's take a look at how a clinical assessment works in the real world. I'll turn it over now to Beverly Morris and Kim Morris, who will share their experiences at CORE. Beverly had collaborated with Cardinal Health in the past to develop a procedure pack program, so she already understood the value of performing a clinical assessment. But CORE had some unique challenges, as Beverly will share with you now.
Thanks, Deb. Well, we've had to open our new surgical hospital in just 90 days from the time I came on board. I came on board in mid-April of 2015, and we did our first surgery July 22nd. In mid-April, we still had walls going up. It was a lot of work that needed to be done quickly and concurrently. So we divided the work into two steps. First, we developed a new procedure pack program to eliminate waste and reduce inventory and align our case mix as well as we could based on the surgeons that were coming to the facility and previous packs that I had used in other locations. Then after that, we did a full clinical assessment once we were open to evaluate clinical practices and preference cards. From there, we reviewed data and suggestions and recommendations that were provided to us by Cardinal Health and moved ahead. And finally, we established how we would measure progress, such as the utilization rates of each pack and how often we needed to make changes. So those were our two measures. What helped us work so quickly and efficiently to make our opening happen was the close collaboration between Deb, the Cardinal Health team, and our staff. Deb worked directly on site with us as the new facility was taking shape, being built. As I mentioned earlier, the first thing we did was a thorough review of our PAC program. And then we moved on to our case pick processes, procedure setups, and draping practices. We even evaluated our sacred cows to see if they made sense for our new surgical hospital. One of the things that Deb brought to my attention was there were some people that were putting towels on the back table before they draped, but that wasn't being done consistently in every room. We had hired people from hospitals all around the Tulsa area and in outlying areas, so they had different practices in different places. But based on the efficiency, the efficacy, the integrity of the drapes that we were having put in our packs, we really didn't need to have the towels there as an initial step. So we did some education and we cut down the number of towels in the packs, and we've been real happy with the results. Throughout it all, Deb shared best practices from professional organizations such as ARN and AAMI, as well as key learnings from other Cardinal Health customers. And as a result, the clinical assessment generated suggestions and recommendations for both our PAC program and our clinical practices that we listened to. Kim, would you like to share the results?
Yes, thank you, Beverly. Streamlining our PAC program and clinical practices created several benefits for core staff members and our patients. First off, we reduced our SKU count because we consolidated so many single items into one custom pack. We decreased our bulk stock in our storeroom. Again, our goal was to put as many items into each pack. As you can see by the pictures above, that is our warehouse storage room. It's very limited on space, and so the space is very, very important to us. We improved utilization and less waste. Our goal was to order supplies right the first time. We put one person in charge of this ordering system, reviewing contracts, getting samples, deciding whether to buy or not to buy, what is best for our contract, what works best for the facility. We can't just order a product because someone says they want it. We have a system in place to help with that, which we'll discuss that later. We have better charge capture for the all-in-one packs, one item at a time versus many items. Greater staff efficiency because there are fewer items to handle, everyone can work more quickly.
There are other benefits as well, including improved OR turnover time. And this is something that every surgeon wants, is the best turnover time possible. We have less setup time with the packs, and this is really key for complicated cases, and we do a lot of those with spine surgery and total joints. There's less individual sterile items to open. We just open the pack and then put our things out. We pull the custom packs the day before each procedure. So the pictures that you are looking at, the top one is of 2 of 7 racks that we have in our sterile storage area. You can see on the left some of the custom supplies, and the bottom one is a case cart in progress, but we've got those packs on there. So we have better space utilization with a just-in-time inventory and delivery. We review, first of all, we set par levels so that we always have something in the bin and never let it get below a certain level. But we also review caseloads 2 weeks in advance to make sure that we have present the amount of packs that we need in order to meet those cases, or else we're ordering. We don't want to get caught by surprise. We order and receive products twice a week, and that helps us a lot in managing volume in these small areas. One thing that's been really helpful for us is we're in Tulsa, Oklahoma. Cardinal Health Distribution Center has a distribution center in Dallas. That's just a day away from us, so we can have extra product there that we might need quickly, and that again helps us utilize our space well. We all know that when a case starts, the only person that can leave the room to get anything is the nurse, because everyone else is scrubbed in. So we want to make sure that we're not running for supplies, and utilizing the PAC program, analyzing it and making it just right for our procedures has accomplished that, and nurses are leaving the OR infrequently in order to get supplies for a case. Cost savings, we are realizing that because we've identified exactly what belongs in each pack, and we're not wasting or pulling extra items or running out of something. We had a really good example of that when we first opened. We had a total knee pack and we had a total hip pack, and there were times that we didn't have the correct pack available for the surgery, and we'd have to adapt and pull some extra things, and then some things would be wasted. Our staff looked at it and said, we think we could just do a total joint pack and it'd work really well. You'd only have to add this or delete this. Anyway, they came up with it. We put it together and tried it, and it's been fabulous. We love it. We have quarterly reviews that help ensure each pack remains aligned with its related procedures. And so far, the total joint pack has met the test of time. So all of these results established 3 demonstrated practices that ASCs and surgical hospitals can follow.
Here are the 3 best demonstrated practices. Strong PAC program drives standardization and cost savings. Clinical and operational alignment helps ensure success. Data analytics to quantify progress and help facilitate improvement. Let's review each one of those in more detail. The first is creating a strong PAC program that drives standardization and savings. The key to standardization is making each decision based on clinical needs and your GPO contracts. I have my GPO contracts on my desk every day, a fingertip away. I check them every time an order is placed. There are prices and utilizations that increase and decrease that help me qualify for better tier level and different tier pricings. That is up to you to follow up on your tiers and make sure you're buying on contract. Look at your pricing, look at your rebates, make sure you're doing it right. Your vendors are not going to call you and say, hey, I can save you money if you do it this way. This is up for you guys. It's a big, big cost savings. You can achieve tremendous savings if you pay close attention to your contracts and your rebate programs. It is also important to identify and combine all supplies for each procedure in a single pack from OR setup to cleanup. If there's boxes sitting on your shelf, that's dollars sitting on your shelf. Do you really need it that way? Is there a way you can reduce your contracts or reduce your inventory to get your impacting quality and timeliness down for patient care? By taking this approach, you can greatly improve efficiency, just as we did at CORE in so many ways. First off, by reducing your SKU count. Less storage space needed in your OR and your storerooms, less time managing supplies, and lower inventory carrying costs. Support inventory reduction goals. Minimize need for clinicians to leave OR and pull supplies. Storage areas close to where the clinicians need their supplies, for them easy to see, easy to pull as needed. This improves workflow efficiency. Replace time-consuming processes for supplies. Help surgeons make the best use of their time. They will appreciate that.
Another best demonstrated practice is clinical and operational alignment. And collaboration is key here. I cannot stress enough how important it is for the OR director and the materials management director to have a strong working relationship in order to improve efficiency and cost savings. I've been real fortunate in this position to work with someone who sees this as I do. Kim and I have worked together tirelessly during the last 2 years in order to move us forward to the place we are now. One of the things that we also utilize, a really good tool for keeping looking at efficiency and cost savings, we have a committee that meets. It's called the Surgical Services Management Committee. We meet every 2 weeks. It's comprised of representatives from administration, surgeons, anesthesia, the surgery management, and all of the components of surgical services, as well as materials management. And then we bring in people as needed if we have x-ray needs or we have housekeeping issues. And then the nursing manager for the floor is also at the meetings. One of the standing agenda items on our meeting is looking at new requests, either new equipment requests, new product requests, but we are evaluating it from all of our points of view in the committee. And we're looking at, why is this requested? Does it replace something that we already have? What is the improvement? What is the cost? What kind of procedures will it be used on? Do we want to make a decision to go forward with this? Or maybe it's not the best decision, period, or maybe it's not the best decision at this time. But we talk through all of this, and when we come out of the door from the meeting, we're all on the same page. So if any of us are approached individually by a surgeon, anesthesia, a staff member, we're able to relay the committee decision, and we all feel like we're making good decisions. If we need a decision on something that's a pretty big impact on either efficiency or finance, and it's another week and a half before the meeting, we can call special meetings We're not afraid to do that. But it's good to know that we have the every 2 weeks so that we can just put that on the agenda and talk about it when we're there. It's essential to gain support from clinicians that are actually using the PACs. And I think that we talked about that with creating the total joint PAC instead of having it separate for knees or for hips. But our surgery staff depends on the PACs, and they want their PAC to be there to have it for their case, and they're good to look at what they might not be using because practices do change, or something that they're pulling every time so that we can make sure it's meeting the needs. One of the really key things is that a fellow clinician is performing the clinical assessments, and by this I mean a perioperative nurse. As a perioperative nurse, Deb has experienced what we're experiencing. She's been in the trenches. Importantly for me, she's a fresh pair of eyes that can spot opportunities that we might miss as we go about our daily routines. As an example, in your home, how many times have you walked down the hall past a sock that's laying there and it doesn't need to be there, but you're focused on something else and you just walk past it? But a guest or your mother coming to your home is going to notice that first thing. Well, that's the function that Deb serves for me and for other areas, other places that she does the assessment. But she's the fresh pair of eyes, and I really value that. And then, of course, the new products review program, again, that's part of what we look at routinely in Surgical Services Management Committee. But we make sure that anything that we're looking at that's new must be clinically significant and or create cost savings to change. We need clinical and OR perspective on product decisions.
I, for one, really love the new product review program. I'm the one that's standing outside Beverly's door dancing, saying, look what I just found. It's going to save us all this money. And I get so excited, and Beverly's like, okay, let's take a look at it. And if it is worth going on, we will pursue it, because sometimes that's where this other set of eyes comes in and helps us all to look at it, because I'm looking at the bottom dollar of saving $427,000. And then Beverly's like, okay, Kim, let's look at this. Is it billable? Can we do this? What else do we have to buy? Do we have to buy capital equipment? All the other stuff that I forget about because I'm just seeing the bottom dollar there. So first off, communication is the #1 most important thing. Sometimes cheaper is not always better. Did I just say that? It's hard for me. I can't believe I said that. Cheaper is not always better. I'm going to have to Beverly might write that one down. Okay, our third best demonstrated practice is using the power of data analytics to enhance performance and optimize the patient experience. Here are the major steps that we're taking right now at CORE to leverage data analytics. First, we're establishing a data warehouse. Instead of having data stored in literally hundreds of different places, the goal is to have one centralized repository for it all. Next, we're using our data warehouse to create customized dashboards for analyzing specific data. For example, our revenue cycle dashboard tracks and analyzes monthly trends from a wide variety of viewpoints, such as inpatient versus outpatient, income, and the various average days of stay in the hospital from conducting the procedure to the billing for it. Another dashboard example is our physician dashboard, which enables us to see individual physician data on a very granular level. For example, we can track such key metrics as numbers of cases, gross revenue per case, gross revenue per physician, implant costs, or our OR turnover times. Again, all of these metrics apply to individual physicians, so we can meet with each physician, share this individualized data, and work together to inform purchasing decisions. Lastly, we're comparing our data with industry benchmarks to see, for example, if we're paying what we should for implants and for supplies. If not, we have new leverage for manufacturers to align our costs to the industry benchmarks. What is the next step for our program? To continually improve. We conduct a semi-annually business review for PAC standardization and utilization. which packs are efficiently turning over, which ones are slow movers, additional savings by converting to Cardinal Health branded items, and contract rebates. Number one most important thing is our essential reward rebates that we get with Cardinal. If you look on your contracts, it tells you which product they prefer you buy. And if you read down further, you'll see that there's rebates. If you do buy on contract, you get so much back. And ours is called Essential Rewards. I love every quarter getting that big check to see exactly how much we save the hospital by buying what we're supposed to, when we're supposed to, and the quantities we're supposed to. It's a big, big, big thing. New clinical assessments are done about every 18 months. We have a proactive review of change with new physicians, new procedures, and new opportunities to improve. Are always open for something new.
So we've given you a lot of information, and there's a few things I'd like to share with you as a result of our experience with clinical assessment. I hope these thoughts will help you as you go on your own journey to identify and implement best demonstrated practices for your organization. First, I recommend that you be open to the clinical assessment recommendations. It's never easy to have someone come into your house and tell you that if you changed your work process just a little bit, you could save 5 or 10 minutes, which over the course of the day can multiply out to some big time efficiencies. Or to tell you that maybe you've overbought on certain things and you should be looking at beefing up in other areas and holding on some. But these clinical assessment recommendations are made based on the experience of the person that's doing the clinical assessment and based on what they see with our practice. So it's, I think, real important to give credence to those recommendations. You may not accept all of them, but be open to them. And the next thing is give yourself permission to change. A lot of people, and I think I could include myself on that, sometimes develop a really great process at some point in your career, and it's hailed as being really wonderful, a game changer. And you continue with that process for the next 10, 15 years, and things change. Technology changes. The way procedures are done changes, and you need to be able to change too, if it makes sense. So you always need to be looking at doing things the same way. Is that really the best thing? And should I be looking at making a change? Speaking of change, I know that all of you have studied the change effect, but just remember that change affects everyone, and you've got to support that process. When we as leaders are presented with a change, be it a recommendation or a mandate, immediately our thoughts turn to the change, and our performance and our morale is probably not as high as it was. It kind of dips down. And we kind of wander along in that lower valley there until we begin to say, oh, well, I could do this, or I could do this, and that would implement this. And at that point, we rise back up, at least to our previous level of performance and morale. Most often, it's a little bit higher. Guess what? That's the point at which we introduce it to our staff, and they are going to go through exactly the same process. They're going to be asking questions about why, and I know that I used to get a little irritated because I'd think, I've already been through this, and I'm giving you the best thing that I can think of, and that has come highly recommended. But you have to support that process for change and allow your staff to work through that. They'll get there. They'll probably get there pretty quickly with your support, and we'll be back up to a better performance level and morale. It's always worth it to support your staff, be open, let them feel like they're part of the change process. It's very much worth it to support that process. So to wrap it all up, I want to say, when you're looking at change, you're looking at doing something different in the organization, the first thing you need to do is put your feelings in a container. put the lid on it and set it aside. Because emotions, if you let emotions dictate your processes, you never have the best processes. We need to be looking at all of the recommendations, all of the parts. You may not implement everything. It may just be a part of it, but you can't let emotion get in the way and be an obstacle.
Thanks. Thank you, Beverly and Kim. It's been a joy to share this journey with you. We started a couple of years ago. I've been back many times since then, and it's a real pleasure to visit your surgery center every time I come. So you've just seen how CORE benefited from a clinical assessment. With your own, you'll learn how to convert waste into real savings, evaluate your current clinical practices to support patient safety, patient and clinician satisfaction, and OR efficiencies. You'll see how to optimize your PAC program for your case mix, and ultimately, you'll discover best demonstrated practices that you can use right away to take back more time for patient care. It's a proven way to get a fresh look at the relationships and financial impact between your clinical practice, supply chain management, and operational processes. The results can have a profound impact on your organization. Best of all, a clinical assessment is a service provided at no cost to you by Cardinal Health. So as we wrap up our presentation today, I'd like to once again thank Beverly and Kim for sharing their experiences and insights. I'd also like to thank you, our attendees, for your attention. We'll now be happy to answer your questions.
Well, thank you, Deb, Kim, and Beverly, for that fantastic presentation. We will now begin today's question and answer session. And please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we will try to get through as many questions as we have time for. We'll go ahead and start with the first question that came in. And it is, and this question is for Kim. And it is, customization is important to our facility. If we standardize our packs, does it take away our ability to customize?
Absolutely not. The goal for any standardization project should be to create a PAC program that meets the needs of the end user, support your procedural demand, and contribute to the financial health of your facility. When a standardization project is approached with these goals in mind, customization becomes the linchpin that promotes the process and drives success.
Great, thank you so much for that. And moving on to the next question, it is, Beverly, my ASC is half physician-owned, and we struggle with standardization because physicians want what they like and or normally use. Any tips on how to get them to see the cost savings in certain supplies?
This is a common problem in any physician-owned ASCs and any hospitals that have physician investors. The physicians feel like, oh, I've got ownership in this. I can get what I want or what I need. But we found that physicians respond to data and to numbers. So we identify what those items are, and if we found equivalent substitutions, then we present the two products to the surgeon with the annual cost of each product and the annual cost savings if we switch to the alternative. If the center is half owned by physicians, it's their money that's going to be impacted by the shift. And usually, by showing them the products side by side and the cost side by side, they may get on board. Another thing to consider is be sure to clarify where that complaint or suggestion is coming from, whether it's actually from the physician or whether it's from the staff. Many times the staff preference rather than the physician preference is what's communicated, but they're communicating it as a physician preference. In reality, most commodity products that are used in the OR are not physician sensitive. One of the things that I always do, and Kim does this too, when we get information from a rep or from a staff member that Dr. So-and-so said he hates this product X and he doesn't ever want to see it in his operating room again, we thank them for the information and immediately find a time to talk with the physician and say, this information was given to me and I need to hear from you because you know I always have to hear it from you before I'm going to make a change. Do you want this change? Sometimes they say, absolutely, I've looked at it, this is what I want to do. But just as often they'll say, well, no, I didn't say that, or I don't want that. So it's good to verify your source before you act on a change. Another thing, if you have a physician that's being a little resistant to looking at things or making a change, if you have identified a physician champion that can help you with that, someone that is using the product, even better, one that has changed to the product and is having good success with it, is good to have them talk to a physician that may be a little bit resistant, and that can help you to drive change in your organization.
Well, thank you so much, Beverly, for all of those tips. And it looks like we have time for one more question. And this question is for Deb, and it is, if I wanted to embark on a clinical assessment journey tomorrow, where's the first place I should start? I know we have an opportunity to cut down our disposable spend with our facility. How can a clinical assessment help me find ways to reduce this spend?
Well, during our clinical assessment, we look at inventory and establish par levels of disposable products to review and determine if there are opportunities to reduce that inventory. Based on what products are getting pulled during the case pick process, we'll determine if the packs meet the current case needs or what might be needed additionally. If there's a pack program in place, we can look at what is getting pulled in addition to the pack. But if there is no current pack program, we can evaluate what supplies are utilized during procedures and build consolidated supply packs so that the overall inventory can be decreased from the shelf. Many times, items are added to the case pick that may not be used just because we want to have them in the room with us. But then those items can be returned to the shelf, and that's what skews par levels, causing more product to be stocked than is actually necessary. Finding the right products to meet case needs and establishing accurate par levels of inventory is always the goal.
Well, thank you very much, Deb, for your insight as well. And that is all the time that we have for today, but I want to once again thank Beverly, Kim, and Deb, and Cardinal Health for their excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.